All right, everyone, we will get started in just a little bit. If you are just joining us, welcome, welcome. Thank you so much for attending. If you don't mind opening your chat box and saying hello, telling me where you're from. And also, I want to just encourage you all to pay attention and stay active and engaged for this 1 hour and 15-minute session. I promise you that there is going to be a lot of high value information. So definitely just make sure you cut out all of your distractions and stay active and engaged with me. Can't wait to start in just a few minutes. All right, everybody, it is just about 10 a.m. Eastern time, and I am so excited for you to join me today for this high yield NBME top concepts. We are going to be going through hematology. Ladies and gentlemen, if you are just joining us, I welcome you. Please feel free to open up your chat box right now. Say hello. Tell me where you are logging in from. I have been so excited to do these webinars as we have really had now an international audience. We have people from India. We have people from Jamaica. I see people from Guyana, New York, Georgia. This is absolutely awesome. And I'm so excited that we can review together in an active recall way. I wanted to first start with a little bit of an introduction. If you are new, welcome. My name is Rahul. And if you've been to my sessions before, I also welcome you back. I am a pediatric critical care fellow, currently in my second year of fellowship. And over the past 6 years, I have been absolutely passionate about helping students just like you kick ass on the USMLE exam. Here's my contact information, and feel free to reach out with any questions. I'll be also doing a live Q&A at the end of this webinar so that we can review together. So before we get started, I do want to just share with you what makes HiGuru unique. I know there are so many other resources that you're probably using for your USMLE preparation, but just give me a few minutes of your time here. I have focused my HiGuru curriculum on evidence-based approaches in medical education. All of my lectures, like today's, are going to be delivered in an active recall manner. I'm going to integrate a lot of different concepts. We're going to go into some biochemistry, some microbiology. We're going to use some multiple choice questions to spring into those concepts. And then finally, I've been really passionate about helping students develop great test taking strategies so that you can hybrid both content as well as application. So when students go through my courses as well as prepare with me in small groups or one-on-one, I really try to focus on 3 prongs. Number 1, I'm going to focus on content as well as test taking strategy. Number 2, I'm going to be making sure that the student is going to have a solid test-taking psychology in the sense that they stay positive and motivated. And finally, number 3, I really focus on how to be extremely productive in your preparation. And I have a nice study plan on Notion, which I'll highlight to you towards the end of this webinar. But apart from this High Guru program, even if you don't go through any of my courses or do tutoring with me, the key thing that I want you to recognize in your preparation is that you have to make sure that you are able to apply content. You have to develop a systematic approach to test taking for yourself that you can stay consistent with. You also have to make sure that you stay positive throughout the process. Don't be afraid to get questions wrong, because you might as well get these questions wrong while you're practicing rather than on test day when you're in the battlefield of Prometric going through your 7 blocks. And then finally, I would say making a schedule, executing the schedule, but most importantly, raising your habit to the power of consistency is going to be the secret to your success. There is no magic study plan. It is the plan which you can stay consistent with. Most importantly, and we have over 100 people joining us today for this webinar. Most importantly, I want to let you know that High Guru is an absolute community. We are both online and in person, and I absolutely enjoy connecting with students. Here are some pictures from the live courses, which I used to teach. And now I've really grown this into a global community of lifelong learners. And I am so excited that each and every one of you are logged in today to go through hematology. So what really inspired me to create this webinar was honestly a Reddit post that captured the most recurring concepts from the NBME practice exams. And as many of you know, I have done webinars in the past covering cardio, endocrine, GI. Today, we're going to be going through hematology, but I have synthesized each of these topic points into my free Notion study plan and outline. And I'd encourage you to visit my website and check that out. If you have not seen my prior webinars on cardio, endocrine, and GI, I would not only encourage you to subscribe to my YouTube channel and watch those 1-hour reviews on my YouTube channel, but you can also now go under free resources. And if you enroll in this Golden style course, you will be able to see all of the videos actually broken up for you. And this is absolutely free. Make sure that you go through each of these videos, complete the whole course curriculum. And at the end, I did put a little certificate for you if you complete those lectures, just so that you have something to look forward to. All right, so that's enough of an introduction. If you are ready to get started with hematology, go ahead and type in yes into the chat box. All right. Simone, Kelly, Funmi, Andrew, Jamie, Gordon, Anshul, Mantra, Monique. Man, we have so many people here. I am so pumped to get into this. And please make sure you cut out distractions. You save your questions till the end. I will do a live Q&A. And then finally, you stay engaged in that chat box. Keep typing the answers in the chat box, because when you type, you're able to remember some of these questions. All right, so let's go ahead and go into hematology. And I first want to just take a big picture approach and just go into what is blood. Well, blood is actually going to be made up of primarily 3 components. You have your plasma, you have your platelets, your red blood cells, and a small component is this buffy coat, which has your immune cells. What is important for you to know is that plasma is the extracellular matrix of blood. It is the stuff that your WBCs, RBCs, and platelets float in. And so plasma is primarily composed of water, but as you can see, there are some nutrients, some hormones, and some electrolytes that also are going to comprise plasma. Now, you may hear on your exam or in your studying the term serum. And what serum is serum is a subcomponent of plasma, but to make serum, we take out the clotting factors. And so serum does contain antibodies, hormones, antigens, but does not contain clotting factors. What we also need to understand is that the buffy coat of blood primarily is going to be composed of your immune cells. And so on the USMLE, you do need to know that high neutrophil predominance means that there is going to be a bacterial infection. High lymphocytic predominance, that may indicate that there is going to be a viral type infection or even a fungal infection. With parasitic infections and allergic infections, you may see increased amounts of eosinophils. So this is going to be an integrative way to go through the material. And I'm going to try to pull many test questions from various question banks so that you can really synthesize all of the content you've been doing. So with that background in mind, let's go ahead and go through the broad overview of what we're going to be covering today. So what we are going to be going through is the basic CBC. When you all are on your clerkships, you will see this fishbone diagram. And this fishbone diagram basically has different components that we look at when we order a CBC. You have your white blood cells, you have your hemoglobin and your hematocrit, and you have your platelets. And so I'm going to split up this webinar to address each of these components. What we'll first do is go through hemoglobin and hematocrit issues. So the topics that we're going to be going through that are very high yield for your NBMEs are first starting with heme synthesis. We're going to be going through a test taking strategy on how to approach a blood smear. I'm going to be breaking down anemia for you. We're going to go into HUS, hemolytic uremic syndrome, and TTP. And then finally, we're going to end with polycythemia. Let's go ahead and first talk about a very important biochemistry concept, and that is going to be heme synthesis. So if we take a big picture approach, we say hemoglobin is actually going to be composed of both heme and globin. And heme is going to be made up of iron and protoporphyrin. So what you do have to understand is that when you're talking about heme synthesis, it's all about making this protoporphyrin ring. And then at the end of heme synthesis, we have iron that is incorporated in the protoporphyrin ring. And that is an important reaction that occurs at the interface of the cytoplasm and the mitochondria. And that enzyme is known as ferrochelatase. Globin is actually going to be a protein. And as we know, there are alpha and beta chains. But let's just focus right now on heme synthesis. So heme synthesis, I want to ask you all, where in the cell does this process occur? This occurs in the cytoplasm as well as the mitochondria. Now, let's just integrate here. What are other pathways which have cytoplasm and mitochondria organization? And that's going to be your urea cycle as well as gluconeogenesis. The key reactions that we have to understand are going to be the following. The first one is going to be the rate-limiting enzyme, and that is going to be delta allosynthase. Remember, if the USMLE asks you, what is the amino acid precursor to heme? The answer is going to be glycine. Porphyrobilinogen to hydroxymethylbilane is going to be catalyzed by the enzyme porphyrobilinogen deaminase. And then you have uroporphyrinogen to corporoporphyrinogen, and that is going to be UROD or uroporphyrinogen decarboxylase. So just for argument's sake, we can say that this is PROD and then this is UROD, just so that we can keep it simple in our minds. All right, so here is the whole pathway. And I told you that the big picture approach is that we first need to make the protoporphyrin ring, and then we're going to incorporate iron into it so that we make heme. Now, what I will advise you is to really focus on the rate-limiting enzymes as well as the portions of this pathway that are going to contribute to pathology. That's actually very important for us to know. So what I first want to go through is the pathology that occurs right here. And this is going to be an issue with delta allosynthase. Now, what we can integrate here is if a patient on your USMLE presents with anemia and basophilic remnants of our RNA, essentially basophilic stippling. This is going to be related to sideroblastic anemia, which is an X-linked disorder. The second area, which I want you to focus in on, is this porphyrobilinogen to hydroxymethylbilane conversion. Remember that the enzyme that catalyzed this was going to be porphyrobilinogen deaminase. We said that affectionately as PROD. And so when patients present with this enzyme deficiency, they are going to have intermittent abdominal pain, port wine urine. And so this is called acute intermittent porphyria. The symptoms are acute, the abdominal pain is intermittent, and it's a porphyria because it is an enzyme defect in PBG deaminase. Finally, I want you to focus on this enzyme reaction, and that is going to be uroporphyrinogen to corporopporphyrinogen. And if you have a deficiency in this specific pathway, you are going to think of porphyria cutanea tarda. Now, with porphyria cutanea tarda, the USMLE loves for you to note that it is a patient who presents with these painful blisters, typically after sun exposure, and these patients can also get some red urine. This is going to be a defect in that UROD enzyme. So remember, acute intermittent porphyria, contrast that with porphyria cutanea tarda. Remember, acute intermittent porphyria doesn't necessarily have skin lesions in your test questions compared to your UROD deficiency, which is going to be porphyria cutanea tarda. So just to go into this a little bit more, the mnemonic that I want you guys to synthesize in your mind is the P's. Acute intermittent porphyria, you have intermittent painful abdomen, port wine urine, you get sensory deficits, so polyneuropathy, and you can even get some psychosis due to the buildup of the precursors of protoporphyrin. The other aspect which I want you to isolate, and this is always shown up in vignettes, are these drug triggers that can actually cause you to have an attack, i.e. the painful abdomen and the port wine urine. Now, some of these drug triggers are going to be CYP-inducing drugs, as well as anticonvulsants and alcohol. So let's go ahead and just integrate a general pharmacology point, and that is going to be going through CYP inducers. The mnemonic that I like to use for CYP inducers goes back to a little bit of integration with beers. Guinness, Coronas, and PBRs induce chronic alcoholism. So Guinness stands for griseofulvin. The mechanism of action of griseofulvin, it inhibits microtubule function, and we use griseofulvin for tinea capitis and tinea unguenum. Carbamazepine is going to be an anti-seizure medication that inactivates sodium channels, and we use carbamazepine for trigeminal neuralgia. Now, remember that the side effect for you to know on your USMLE for carbamazepine is SIADH, in which patients on carbamazepine may actually develop hyponatremia. Phenytoin, barbiturates, and rifampin with St. John warts, that is going to be PBRs. So let's go into this. Phenytoin, another anti-seizure medication. It inactivates sodium channels. See that pattern? You can get a very severe desquamating mucosal skin rash known as Stevens-Johnson syndrome. And just from a gen path, remember that phenytoin actually undergoes zero order kinetics, which basically means that a constant amount, not a constant proportion, but a constant amount of the drug is removed from the circulation. Barbiturates, I like to call barbiturates because they increase the duration of the GABA chloride channel opening. Remember, barbiturates are going to cause you to have CNS depression as well as respiratory depression. And so what type of acid-base abnormality can you get on your exam if you have respiratory depression? If you said a respiratory acidosis, you're absolutely correct. All right, next one is going to be rifampin. Now, I like to say that rifampin ramps up the CYP. So it helps me also remember that it is a CYP inducer. Remember that rifampin is actually going to block DNA-dependent RNA polymerase. So if you are going to have less mRNA, you're not going to be able to even go through translation. So it inhibits bacterial protein synthesis. Rifampin, along with isoniazid, is going to be used for tuberculosis treatment, as well as prophylaxis. If you were exposed to, for example, somebody with meningococcal or HIV. The last herbaceutical that we're going to be going through here is St. John worts. Now, St. John worts is going to be used for depression, and it increases serotonin levels. So the summary: Guinness, Corona, and PBRs induce, and yes, chronic alcoholism is going to be a CYP inducer. So always watch in your USMLE questions. I'm just going to give you a test taking strategy. And that is that if you see 3 or more medications listed in the medication sentence in your vignette, you should be thinking about some drug interaction, and especially the one that is classically tested with CYP inducers and inhibitors are going to be medications like warfarin, as well as oral contraceptives. Very important for you guys to know. All right, so let's just make this a little bit fun. If you had a choice to drink one of these beers, which one would you guys choose? Go ahead and put that in the chat. Guinness, Corona, or PBRs? Which one? All right, we have some Corona, Guinness. Awesome. We have a nice spread of various different beverages here. That's great. All right, let's go ahead and go into a test question that is going to be very important for us to know. So here we have a 4-year-old male who presents with cramping and abdominal pain. He has generalized weakness and decreased feeding. His father works as an industrial laborer. Family history is unremarkable. He has no other siblings, and his labs are notable for an anemia with a low MCV and an abnormal blood smear. Which of the following mechanisms may underlie this patient's condition? And so if you said that this is going to be lead poisoning because of the father's industrial exposure, as well as these non-specific symptoms, you are going to be absolutely correct. And remember that lead primarily inhibits ferrochelatase. Now, what is ferrochelatase? Remember, it is going to be that enzyme that incorporates iron into the protoporphyrin ring. So let's go into lead poisoning just a little bit more. And this is exactly where lead poisoning hits. Now, there is another enzyme which lead poisoning hits, and we will get into that. But you do need to know ferrochelatase is going to be inhibited by lead, very high yield. So where is this enzyme located? And this enzyme is located in the mitochondria. The majority of protoporphyrin synthesis occurs in the cytoplasm. However, this last reaction is going to be in the mitochondria. So lead poisoning inhibits ferrochelatase as well as delta alla dehydratase. And that is going to be in the proximal portion of the pathway. What will the blood smear show? The blood smear here is going to show basophilic stippling. Very important for us to understand. Now, this represents remnants of rRNA. And so we will cover this in the peripheral blood smear section, but just recognize that when you're studying, if you see remnants of something in a cell, you do need to take that one step behind and say, man, what does that represent? And so basophilic stippling represents remnants of rRNA. So the USMLE point for you to recognize lead poisoning is for you to recognize essentially non-specific symptoms. So children, for example, can present with developmental delay. Another important clue will be if other family members or other siblings have issues as well. This is going to be notable in not only lead poisoning, but for example, in carbon monoxide poisoning, because in carbon monoxide poisoning, everybody in the household may be affected. All right, so the next portion that we are going to be going through is the approach to the blood smear. All right, so the first thing that I want to let you know is that in USMLE multimedia questions, it is very important for you to not just focus on the picture, but most importantly, go focus on the vignette, because the vignette sets you up for you to interpret the picture. And so one of the key points, and this is from my test taking skills class, is that the image should be correlated to the question. And the image should confirm the concept being tested in the vignette. So the extreme example of this is for you to recognize that sometimes you may not even need the image, but the image is there to actually confirm what's in the vignette. Very rarely in USMLE questions are they just going to say, here's an image, interpret it. And so I would encourage you to always look at images with the vignette. All right, so what we will be going through is the test taking strategy on how to go through peripheral smears on your USMLE. The first thing that I want you to note, that I want you to integrate in your mind, is to paraphrase the vignette to isolate what kind of pathology you're going for. The peripheral blood smear is going to confirm your paraphrase. And what I want you to do is essentially look at the peripheral blood smear and see where there is asymmetry, i.e., where there are cells that are going to be different from the normal background. So this is going to be a normal peripheral blood smear. You're going to see a variety of cells. You're going to see neutrophils. You're going to be seeing precursor cells, as well as primarily you will see red blood cells, because that comprises a lot of your blood. So let's go through this test question. A 30-year-old female presents for follow-up. She is status post a splenectomy 1 year ago after a motor vehicle accident. She currently feels well, and physical exam shows no abnormalities. Lab studies are notable for a mild anemia. Her peripheral blood smear is shown. An increase in which of the following best explains the presence of these abnormal cells? A, aggregated iron deposits, B, clusters of remnant DNA, C, denatured hemoglobin, or D, high erythrocyte cellular membrane to internal cell volume. And so we have a bunch of different answers in the chat. Go ahead and put something in the chat so you can stay active and engaged. And so as we see in the peripheral blood smear, we note some target cells right here and correlate that to what aspect in the vignette, and that is going to be the splenectomy. And so what happens when you don't have a spleen is that you are going to have a very high cell membrane of the erythrocyte. Why is that? Because the normal job of the spleen is to kind of chomp up at any excess or redundant cell membrane of the erythrocyte. And so if you don't have that, you can get a high erythrocyte cellular membrane to internal cell volume. So let's go through and integrate causes of target cells on the USMLE. Target cells, you want to be thinking of hemoglobin C disease. On your exam, that's going to be a patient with hemolytic anemia, just like kind of sickle cell, splenomegaly, which indicates that there could be some functional asplenia. And remember that this is a glutamic acid to lysine transition. Asplenia, which is what we talked about. And remember that this is going to be a patient with sickle cell who could be functionally or anatomically asplenic, or the patient who ends up becoming anatomically asplenic because of a motor vehicle accident. Liver disease can also cause this. And so watch for the patient with alcoholism, obstructive liver disease, in which you are unable to regulate your portal circulation. And then finally, think about thalassemia. And thalassemia is going to primarily be categorized in alpha or beta thalassemia. Remember, in beta thalassemia, you're going to get extramedullary hematopoiesis. So these patients are going to have the hair on end appearance of the skull x-ray, these chipmunk faces, as well as chronic transfusions. And so you're absolutely correct that the mnemonic here is going to be H, hemoglobin C disease, A, asplenia, L, liver disease, and T, thalassemia, halt. So The way to think about target cells and the pathophysiology of it, I'm going to break it down for you right here, is that target cells could be due to the internal red blood cell mass actually being low. So right here, this area ends up being low and it shrinks down. And so that's going to be the case in thalassemia, in which you have an abnormal production of that globin chain. The other aspect that you can think of is that this area right here, the membrane, is actually very redundant. So we saw that in post-splenectomy patients as well as in liver disease. So not only are you going to have in your mind the mnemonic to synthesize, but then you can go a little bit deeper and you can understand why. And both of these together really help with long-term potentiation and memory. All right, so just to summarize our peripheral blood smears, let's go through this table. Now, the headings of this table, I'm going to go through a USMLE vignette. We're going to synthesize some high-yield pathology, and we are going to go through the blood smear together. So an alcoholic or a patient on isoniazid for tuberculosis, remember that isoniazid can cause a B6 deficiency. That can mess up with your porphyrin pathway as well. And so think about basophilic stippling, which represents denatured ribosomes. Functional or anatomic asplenia, remember that these patients can get the Howell-Jolly bodies. The Howell-Jolly bodies are going to represent DNA remnants. Think about this vignette, drug trigger plus normal MCV anemia plus jaundice. So you know that this trigger is causing you to have a hemolytic anemia as evidenced by the normal MCV and the jaundice. Think about G6PD deficiency when you're thinking about the Heinz bodies. And Heinz bodies is going to represent denatured hemoglobin. Now, remember, when these Heinz bodies end up going to the spleen, what are they going to be known as? Go ahead and put that in the chat. Heinz body going to the spleen, what are they known as? Awesome. People are saying bite cells, and you're absolutely correct. Excellent. All right, how about this next vignette? A patient with a low haptoglobin, Coombs positive, normal MCV anemia. So we know that this is going to be an autoimmune anemia. And why is that? Because we see the Coombs positivity. This can give you spherocytes, but you can also have a hereditary defect in cell membrane components, ankyrin and spectrin. And so you could get these spherocytes on peripheral blood smear. And that essentially represents low membrane surface area. So if you don't have good membrane surface area, the actual volume within your RBC is going to be very concentrated. And so you can get a high MCHC, low membrane surface area, because no ankyrin and spectrin, which makes up that phospholipid membrane of your red blood cell. So these are going to be the really important inclusions and aspects of the blood smear. So I really encourage you to revisit this table. All right. The next topic we are going to be going through is anemia. It's a big topic. We are going to be going through it step by step. But first, let's just go ahead and just all take a deep breath. Let's do it together. Come on. All right. Let's go through anemia. Are you guys ready? Go ahead and put that into the chat. Yes or no? Awesome. We have over 200 people joining. Be a part of the movement. I absolutely love it. Let's go through it. So let's go ahead and talk about anemia and how to tackle these questions on the USMLE. When I approach anemia on the USMLE, I first off want to kind of convey to you how the vignette is organized. So they will give you a patient presentation, and then they will give you lab studies. Typically, hematology questions on the USMLE are going to have lab studies. Very important for us to recognize. The vignette is going to indicate anemia. And so the patient is going to have physical exam as well as symptoms of anemia. So what are those going to be? Fatigue, shortness of breath, pallor, angina, tachycardia. And all of these are going to be related to what cardiovascular principle? That is going to be a decrease in oxygen delivery because you have a low hemoglobin. What you will then do is really look at the lab studies. And based on the vignette, you will say, I want to see a low hemoglobin. Good. You saw a low hemoglobin. You've made your diagnosis of anemia, but you're not done yet. What you're going to do then is essentially look at the MCV, and you're going to categorize whether it's a microcytic, a normocytic, and macrocytic. Now, remember, normocytic anemias primarily are what we call hemolytic anemias, in which the RBC is bursting. And so what's high yield is that if you see normocytic anemia, i.e. a hemolytic anemia, you always want to look for the reticulocyte count. The reticulocyte count tells us whether the bone marrow is responding or not. You will have questions, for example, questions related to parvovirus B19, in which the patient doesn't have adequate reticulocytes in the setting of a hemolytic anemia. And so that is what we call an aplastic crisis. But the general principle is that hemolytic anemias look for what the bone marrow is going to do. The other important aspect to keep in mind is the fact that ferritin is your storage form, and it's always opposite from TIBC. Now, I'm not going to go into the details of TIBC, but just remember, ferritin is the storage form. High storage form, i.e. high ferritin, for example, in anemia of chronic disease, low TIBC. In iron deficiency anemia, ferritin is low, high TIBC. They're always going to be opposites, and that will help you crush those test questions related to arrows. So what we'll first do is we will go through microcytic anemia. Let's start with this question. An 18-year-old female presents with fatigue. She has some weight gain. She is an avid tennis player. Menarche started at 12. She is Tanner stage 3 on physical exam. Pale conjunctiva are also noted on exam. So again, a sign or physical exam sign for anemia. Her TSH is slightly elevated with a low free T4. That's really weird. Which of the following additional laboratory findings are most likely to be noted in this patient? A, normal MCV. B, elevated folate. C, decreased ferritin. D, hypersegmented neutrophils, or E, decreased TIBC. What do you all think? Go ahead and put the answer into the chat box. Awesome. We have a lot of great answers. And if you said C, you're absolutely correct. Remember that this is going to be iron deficiency anemia. And I put in hypothyroidism type of stigmata in the vignette just to let you know that hypothyroidism can cause you to have menorrhagia and weight gain. And if you're going to have increased menstrual bleeding, you are going to develop an anemia. So let's go ahead and talk a little bit more about iron deficiency anemia. And I want us to all think like the test maker here. Remember that characteristically, patients with iron deficiency anemia are going to have low hemoglobin, low MCV, and at late stages, they will have high RDW. Now, the high RDW means that there's a high red cell distribution width, i.e. some RBCs are going to look nice and plump, whereas others are going to be very small and microcytic. So there's a big distribution. What are going to be vignettes on your USMLE for iron deficiency anemia? Well, a female in the premenopausal period, an elderly patient with anemia, fatigue, and weight loss. This is where you think of colon cancer. Stay engaged with me. Pregnancy causing a dilutional anemia, as well as a patient who has a nutritional deficiency in actual consumption of iron. So when we look at the pathophysiology of iron deficiency anemia, we first recognize that the first stage is all about depleting your stores. So you have a decreased ferritin. That then is going to progress into causing your serum iron to be low. And obviously then TIBC is going to be high. Why? Ferritin and TIBC are opposites, a good take-home point for you. And finally, you are going to have abnormalities in the MCV, as well as in the RDW. And we talked about how some of them are going to be plump, others are going to be small, and you will have protoporphyrin products that may be elevated as well. So very high yield for you to know. Iron deficiency anemia, the two highest yield vignettes are going to be the patient with colon cancer, as well as the female who is losing a lot of blood through her periods. All right, let's go ahead and talk about another cause of microcytic anemia, and that is going to be anemia of chronic disease. Now, I do want to give you a disclaimer that anemia of chronic disease can sometimes be normocytic. In early stages of anemia of chronic disease, it can be normocytic. And the USMLE will make it very black and white for you. So let's go ahead and go through this question. A patient with rheumatoid arthritis is diagnosed with anemia. What may be the likely classification of this anemia? All right, this is a good question. The patient has rheumatoid arthritis, so there are signs of inflammation. Remember that anemia of chronic disease initially is going to be a normocytic anemia, but then it can progress to a microcytic anemia. The pathophysiology all stems from the fact that there is iron trapping. And because there is iron trapping, you are going to get a high ferritin. Now, why do you get that iron trapping? Well, it's because of cytokines like IL-1. And that cytokine is going to be upregulated in very inflammatory conditions, rheumatoid arthritis, lupus. You also are going to make an acute phase reactant, which is hepcidin. Hepcidin increases in high amounts of inflammation, and that causes you to decrease iron absorption, primarily in the gut. Remember that in anemia of chronic disease, you're going to have a high ferritin and TIBC is going to be low. The USMLE point that I want to give you as a take home is that in the past medical history in your vignette, it's worth noting the high inflammatory conditions. So patients with lupus, rheumatoid arthritis, even a chronic infection in which you have an upregulation of these acute phase reactants. Oh, wait, acute phase reactants. Let's go ahead and do some gen path integration. All right, so with inflammation, the USMLE really wants you to know what are your positive acute phase reactants and negative acute phase reactants. Now, these will be shown in your test question in the labs at times. So positive acute phase reactants, these are the ones that are going to go up when you have a lot of inflammation in your body. So CRP, which is going to be a non-specific sign that fixes complement and increases phagocytosis. Ferritin, we talked about that. Fibrinogen, which is going to be a important component of secondary hemostasis, hepcidin, and this systemic amyloid, which is SAA. And remember that amyloidosis, you get that apple green birefringence characteristically in your test question. Negative phase acute phase reactants essentially mean that when you have high amounts of inflammation, you have low amounts of these negative acute phase reactants. And so the negative acute phase reactants that go down are going to be your albumin as well as your transferrin. Typically, hypoalbuminemia in chronic inflammatory conditions, as well as even in malnutrition, that's going to be very, very important. And just to do a little bit of cardiovascular tie-in here, remember when you have hypoalbuminemia, you are going to have low oncotic pressure. And so you can get this generalized edema. And that's key for like nutritional deficiencies, like kwashiorkor, for example, in which these patients get edema due to loss of oncotic pressure. Very high yield for us to know. All right, so let's go ahead and summarize microcytic anemias. I did put a disclaimer up here in the top screen right here, and that is to watch for questions on the USMLE related to arrows and this concept. How I like to go through this table is essentially looking for the primary deficit. What is wrong? For example, in iron deficiency anemia. Well, you have low iron. And so you have a low iron, and you're going to then have also low ferritin because you're trying to deplete all of your stores. Ferritin and TIBC are opposites. MCV in late stages are going to be low. And then if you do some numerator and denominator type of math, you notice that if you have a low iron and a high TIBC, your transferrin saturation is going to be low. In thalassemia, what I like to say is that you have a deficit in making good alpha or beta globin chains. And so your MCV is primarily going to be low. Now, what I do want to kind of highlight is this test taking point, is that typically the MCV will be very, very low, i.e. out of proportion to the degree of anemia, to the degree of hemoglobin. In thalassemia, you are going to have a high ferritin because you're just going to keep all of that stuff in your stores, and the TIBC is going to be low. Anemia of chronic disease, remember your iron is trapped. So you have high ferritin, low serum iron, ferritin and TIBC are opposites, And so you're going to have a low TIBC, and the rest of them you don't necessarily need to worry about. All right, very good. So this is the summary for microcytic anemia. Let's go ahead and go into the next concept, which is going to be macrocytic anemia. Go ahead and put in the chat. Are you guys learning something? Yes or no? Excellent. Awesome. I am so glad each of you are here. Let's go into macrocytic anemia. So again, this is an innovative and unique way to learn, right? Because I'm giving you a big picture, a test taking strategy, and then I'm going into the concept. Approach to macrocytic anemias. Remember that patients with macrocytic anemias are going to have anemia defined by a low hemoglobin and then a high MCV, usually greater than 100. The subset of macrocytic anemias that are very highly tested are going to be what we call megaloblastic anemias. Now, megaloblastic anemias primarily are going to be B12 and folate. And this is a concept which you definitely have to differentiate. Contrast them by physical exam. Remember that B12 deficiency is going to give you neurological deficits, and that's due to a biochemistry integration. We're going to go into that. And folate, you are not going to have any neurological deficits. Going into this a little bit more, in megaloblastic anemias, your characteristic peripheral blood smear is going to be these hypersegmented neutrophils. Typically, they're going to have greater than 5 lobes, and the pathophysiology is the following. So remember that neutrophils need to replicate, and B12 and folate are really important for adequate mitosis, replication, as well as DNA synthesis, and especially cytokinesis, pulling the neutrophils apart. So as the neutrophil replicates and goes through mitosis, the nucleus continues to expand, i.e., it continues to get segmented. But because you have either a B12 or folate deficiency, you're unable to undergo cytokinesis, and thus you are left with a hypersegmented neutrophil. So B12 and folate, really important for those DNA macromolecule synthesis, as well as the cytokinesis. All right, let's go ahead and go into this test question. A 59-year-old female presents with progressive fatigue. Do you see this pattern? Signs of anemia. She is noted to have a history of hypothyroidism. Vital signs are going to be the following. She's afebrile, she's mildly tachycardic, and she has a mildly low blood pressure. Laboratory studies are notable for a low hemoglobin and a high MCV. We're thinking about a macrocytic anemia. Serum sodium studies are noted to be decreased. Which of the following pathophysiologic mechanisms is most likely noted? A, autoimmune destruction of parietal cells. B, upregulation of renin-angiotensin-aldosterone system. C, chronic inflammation leading to elevated ferritin and anemia of chronic disease. Or D, decreased dietary folate. And so here, the answer is going to be A. This is the vignette for pernicious anemia. Very important for us to recognize the autoimmune stigmata, hypothyroidism, adrenal insufficiency. And this is going to be a key test-taking tip, and that is recognizing patients who have this autoimmune stigmata. Remember that when you have one autoimmune disease, you're more likely to have other autoimmune diseases. So, for example, think about your hypothyroidism patients, your patients who have autoimmune adrenalitis, and that's why the patient in the vignette had a low sodium and thus a low blood pressure. Patients who have albinism or patients who have pernicious anemia. Remember, you get a loss of intrinsic factor in pernicious anemia, and thus you have low B12 in your serum. The pathophysiology is going to be very important for us to recognize, and that is that autoimmune entities are primarily going to be tested by saying type 2 hypersensitivity, because that is an auto antibody to an antigen. All right, B12 deficiency. Think like the test maker here. Who are patients on the USMLE that you may suspect B12 deficiency, especially if they present with a macrocytic anemia? Well, we'll be thinking about, for example, vegans, in which these patients are going to have decreased dietary deficiency or decreased dietary intake of B12. Remember, B12 is primarily found in animal products. Patients with pernicious anemia, which we just saw. Patients with gastrectomy. Why? Because you lose your parietal cells, and thus you're going to lose your intrinsic factor. Patients with malabsorption and diseases which affect the terminal ileum are going to also get B12 deficiency. For example, Crohn's disease patients, or patients who are infected with Diphyllobothrium latum, the fish tapeworm. So now what we're doing is we're integrating not only hematology, but we're making some connections into GI. And I hope that all of this then allows you to remember this information a little bit better. All right, so a little bit of biochemistry integration, and that is going to be going through B12 deficiency. Let's just go into this biochemistry integration with the big picture. The first thing that I just want to let you know, the answer to all of your test questions is that increased methylmalonic acid causes neurological deficits. And the mechanism here is that you have the inability of odd chain fatty acids to plug into TCA cycle. So what that means is that odd chain fatty acid metabolism is not going to be able to get into the TCA cycle. So what is your byproduct in odd chain fatty acid metabolism? Well, it is actually going to be propionyl-CoA. And propionyl-CoA enters the TCA cycle as succinyl-CoA. However, if you have a B12 deficiency, you are not going to be able to have good activity of the enzyme methylmalonyl-CoA mutase. And thus, upstream, you build up methylmalonyl-CoA, and subsequently, you'll get an increase in MMA, and that is neurotoxic. No B12, no propionyl to succinyl-CoA, and then, as a result, you're going to have a high MMA. Normocytic anemia is going to be our next topic. The test taking strategy here is that primarily normocytic anemias are what we call hemolytic anemias, very high yield. With normocytic anemias, the first approach that I want you to recognize is the fact that, okay, I need to actually confirm, am I dealing with an anemia? So obviously you're going to look at the hemoglobin and that's low. Then you're going to look at the MCV, and in normocytic anemias, you're going to have an MCV that is going to be 80 to 100. But then what is that important point that I told you? And that is look for the reticulocyte count, because the reticulocyte count represents the bone marrow's response to anemia. For example, in the periphery, if you're getting actual destruction, i.e. you are getting hemolysis, you want the bone marrow to react by increasing your reticulocyte count. So we define normocytic anemias by actually differentiating whether or not the hemolysis is occurring in the blood vessels or extravascularly, for example, in the spleen. So what's going to be important for you to recognize is that if the patient in your test question is going to have a low haptoglobin, a high LDH, or a high indirect bilirubin, you're going to be thinking of, man, this is going to be intravascular hemolysis. That low haptoglobin is always tested. And the reason why is because as red blood cells are going to be destroyed, they release heme, and haptoglobin binds up heme. More destruction, more free heme, then you consume all of your haptoglobin and haptoglobin goes down. Extravascular hemolysis is going to primarily be presented in your physical exam via splenomegaly, and you'll have a relatively normal haptoglobin. Let's go ahead and go into this just a little bit more. Extravascular hemolysis, we said that occurs primarily in the spleen. So what are going to be causes of extravascular hemolysis? You're going to be thinking of autoimmune hemolytic anemia, hereditary spherocytosis, G6PD, as well as thalassemia. Whereas in intravascular hemolysis, you're going to be thinking of microangiopathic hemolytic anemia, prosthetic heart valves, in which you're going to have, for example, aortic stenosis in your test question, and you're going to get actual mechanical shearing of these red blood cells, as well as paroxysmal nocturnal hemoglobinuria. Remember that this is an abnormal PIGA gene, PIGA gene, you get low decay accelerating factor, and thus you are going to be more susceptible to complement, and thus you are going to get hemolysis. Extravascular, like I said, extravascular, you're gonna watch out for splenomegaly. So when something comes abnormal to the spleen, it's going to start chomping it up. And that's why it's called extravascular hemolysis. So for example, your IgG or IgM mediated agglutinins, your spherocytes, your actual Heinz body and bite cells, as well as issues with the actual synthesis of your globin chains. Another way to look at anemias and hemolytic anemias in particularly is this differentiation between extrinsic and intrinsic. Remember, this is different than intravascular and extravascular. Intrinsic hemolytic anemias means that there is something intrinsically wrong with the RBC. Maybe there's a membrane defect. Maybe there's an enzyme defect. Maybe there is a defect in the hemoglobin itself. This is just another way to categorize normocytic anemias. So when you have a membrane defect, think about hereditary spherocytosis. When you have an enzyme defect, think about G6PD deficiency or even pyruvate kinase deficiency. And hemoglobin defects, you're going to be thinking about sickle cell anemia, as well as paroxysmal nocturnal hemoglobinemia. Let's go ahead and go into this test question. A 20-year-old male presents with cough and fever. The cough is non-productive. He has no sick contacts and attends college. He is noted to be very fatigued. Physical exam is notable for jaundice, and laboratory studies are notable for anemia, a normal MCV, which clues you into hemolysis, and a low haptoglobin. So what kind of hemolysis is this? Intravascular hemolysis. A chest X-ray is shown. Which of the following additional laboratory studies will be present in this patient? So let's go through this chest X-ray. This is a radiograph of the chest, and you see this interstitial pattern on the chest X-ray. What do you think I am going for here? And if you put D, you're absolutely correct. You are going to be thinking about a Coombs positive autoimmune hemolytic anemia. This is going to be essentially your IgM mediated cold agglutinins, and that is going to cause you to have an autoimmune hemolytic anemia. What is the trigger? Well, the trigger is going to be mycoplasma, and that is the microbiology integration, which we are going to do. So with mycoplasma pneumonia, let's go through a couple important points. First off, you note on the chest X-ray, like we saw in our test question, that you are going to have this interstitial pattern. Mycoplasma, interestingly, has a cholesterol cell membrane, and it does not have that peptidoglycan cell wall. That's really important for us to recognize. Why? Because that's why you can't use penicillins or other beta-lactams to treat mycoplasma pneumonia. The pathophysiology is that mycoplasma pneumonia infects the lungs and causes this interstitial inflammation, and that's why you see that interstitial infiltrates on your chest X-ray. And so your key USMLE vignettes are going to be a teenager who presents with the atypical pneumonia. That's what we call a walking pneumonia. Remember that mycoplasma could be a trigger for erythema multiforme. And we talked a little bit about this in our vignette. The pharmacology is going to be important for us to recognize, and primarily we use macrolides. So what do macrolides end at? Thromycin. And remember that macrolides are going to inhibit your 50S ribosomal subunit. All right, couple more concepts that we are going to be going through. The next one, speaking of hemolysis, is going to be HUS and TTP. All right, here's the pathophysiology of HUS and TTP. And this is another test question in which you are going to need to recognize a trigger. Typically, the trigger is going to be a bloody diarrheal episode in a child. And so in that setting, we are going to be thinking of E. coli 0157H7 or EHEC. Remember that EHEC secretes the Shiga-like toxin that inactivates the 60S ribosomal subunit, but most importantly is going to cause you to release cytokines. Now, when you release cytokines, the key thing that you can end up doing is damaging the vascular endothelium. And whenever you have endothelial injury, that is part of a GenPath concept, which is going to be Virchow's triad. Virchow's triad, anemia, Virchow's triad, endothelial cell injury, hypercoagulability, as well as stasis. So in this case, you have endothelial injury and you start forming these microthrombi. And as platelets are going to be going over these microthrombi, you are going to end up consuming the platelets, creating these road bumps and having intravascular mechanical shearing, causing those characteristic schistocytes that you see on your peripheral blood smear. Finally, what's important for us to know is that if this happens primarily in the renal vasculature, you can get the acute renal failure. So in HUS, the triad typically is going to be anemia, thrombocytopenia, and acute renal failure. However, I do want to make sure you integrate the fact that triads on the USMLE are going to have a very important test-taking strategy. And that is that as you are studying, you can't just say anemia, thrombocytopenia, and acute renal failure. I would actually encourage you to take the triad one step further and really look at how the triad will be tested. Now, this is exactly from my rapid review course. And what I want you to really hone in on is the fact that anemia, for example, is tested on the USMLE by saying low hemoglobin, normal MCV, schistocytes on peripheral blood smear. In your labs, they will put low platelets that you're going to have to recognize. And how do they test acute renal failure? High BUN to creatinine. So this is going to be the triad, which I encourage you to think like the test maker. And what do you need to make it the pentad of TTP? You're going to be needing fever. So look for the vital signs. They'll put anything greater than 38 degrees centigrade, as well as altered mental status. And look for that in the physical exam, whether that's headache or peripheral neuropathy. All right, let's go ahead and keep going. The last concept that we will talk about related to hemoglobin and hematocrit is going to be polycythemia. So with polycythemia, guys, polycythemia, the definition of that is essentially you have more red blood cells floating around. Let's go ahead and go through this test question. A patient with a past medical history notable for renal cell carcinoma presents with increased daytime sleepiness. He is obese and he is noted to have an elevated hematocrit. What is the likely mechanism behind this elevated hematocrit? Well, this patient actually has hypoxemia, likely due to obstructive sleep apnea. What does hypoxemia trigger? Well, it triggers your peritubular capillary cells to make erythropoietin, and that then jacks up your erythrocyte production. If left untreated, what do you guys think would a patient with obstructive sleep apnea, what do you think his pulmonary vascular resistance will be? Increased or decreased? Go ahead and put that in the chat. I want everybody to answer here. Awesome. Yeah, because what you're going to have is essentially chronic hypoxic vasoconstriction. And if you have chronic hypoxic vasoconstriction, you are going to have an increase in pulmonary vascular resistance. Now, what does an increase in pulmonary vascular resistance do to right ventricular afterload? Go ahead and put that in the chat. What do you think right ventricular afterload is going to be? Up or down? Put it in the chat. Awesome. See how all of us are coming together as a community in answering these questions? This is awesome. This is great. All right, wonderful. Let's go ahead and keep going here. How to approach polycythemia on the USMLE. This is the mental model. Obviously, you're going to have a high hematocrit in your labs, and you first want to synthesize whether or not they're talking about a JAK2 positive cause of polycythemia, which is related to polycythemia vera, in which other cell lines may be up, and they'll typically say it's a female who presents with itchiness after a hot shower. Or polycythemia could be JAK2 negative. And we went through a cause of that, i.e. chronic hypoxemia. What we notice here is that if you have a high hematocrit, i.e. polycythemia, it could be reactive. It could be reactive to, for example, a cyanotic heart disease in which the patient is going to be a child who is hypoxemic, somebody who has sleep apnea or lung disease like COPD. Or, for example, in renal cell carcinoma, in which you have an EPO-secreting tumor. And that can cause you to have a high hematocrit and thus polycythemia. And this is the clear cell variant of renal cell carcinoma, one of the most common path images that you may get. All right, guys. So we have just gone through the hemoglobin and hematocrit part. We just have a little bit left, and that is just talking about platelets. I wanted to just focus on a test-taking strategy regarding primary and secondary hemostasis. And then we will go into a little bit of pharmacology tie-in, and that is going to be heparin versus warfarin. What I want to kind of integrate is the fact that when we talked about, for example, TTP is a cause or an issue of primary hemostasis. So what is this primary and secondary hemostasis stuff? This is going to be an important concept. And I hope that you approach coagulation disorders just like this. So first, let's get introduced with the test question. A 12-year-old male presents with prolonged gum bleeding. He recently was at the dentist for a tooth extraction. His father and paternal aunt have similar issues following minor surgical procedures, and he has started on DDAVP therapy. Which of the following most likely highlights the therapeutic mechanism of desmopressin in this patient? A, increases von Willebrand factors release. B, increases factor 10 release. C, decreases factor 8 release. Or D, promotes clotting via release of fibrin. And majority of you are saying A, and you are absolutely correct. Remember that it is actually an increase in factor 8 that DDAVP does. And this gives us a great opportunity to go through von Willebrand's disease. So let's go through first the genetics of von Willebrand factor disease. Typically, this is going to be autosomal dominant, and we saw that in the test question. It affects primarily males and Caucasians. And the pathophysiology of von Willebrand factor disease is the fact that you either have a decreased amount or what you do have is not working, a quantitative or qualitative defect in von Willebrand factor. Now, remember, von Willebrand factor, just like a football player hugging a football, is going to actually protect factor 8. So if you don't have von Willebrand's factor, you have no factor 8, and thus you can get issues with primary hemostasis. The USMLE vignettes are going to be very important for us to integrate, and that is this mucocutaneous bleeding that you may see after, for example, a dental procedure or even aspirin use. The pharmacology here is that in von Willebrand factor disease, as well as in mild cases of hemophilia A, in which you have a deficient factor 8, in both of those cases, you can give DDAVP because DDAVP squeezes the endothelial cell to release von Willebrand factor and, as a byproduct, factor 8. All right, so differentiating between primary and secondary hemostasis disorders, I would say for your exam questions, just look at the physical exam. Very high yield for us to know. Primary hemostasis disorders are going to present with mucocutaneous bleeding, i.e. bleeding from your gums, menorrhagia, petechiae, purpura, bruising. Think about issues with the platelet plug, i.e. you don't have good GP1B, you don't have good GP2B3A, you don't have good von Willebrand's factor. When we talked about TTP, what was going on? Issues with the platelet. So primary hemostasis labs are going to be platelet count as well as bleeding time. In secondary hemostasis issues, you are going to have deep muscle or joint bleeding. And so they may say the ultrasound shows fluid surrounding the joint. And so on your labs for secondary hemostasis disorders, you're going to be thinking of abnormalities in PTT and PT as well as in INR. When you're talking about secondary hemostasis disorders, you want to think about issues with the clotting cascade. And the overwhelmingly large bucket of secondary hemostasis disorders is going to be hemophilia. Hemophilia A, where you have a defect in factor 8, and hemophilia B, where you have a defect in factor 9. Think of the mnemonic B9. What's interesting for us to recognize is that A pathology like DIC and a little bit von Willebrand's factor as well, but primarily DIC is a hybrid of primary hemostasis and secondary hemostasis disorders. In DIC, you're going to get, for example, low platelets, you're going to get a high bleeding time, and you're going to have abnormalities in PT and PTT. So DIC is a blend of both. And typically, DIC in the test question is going to have some sort of trigger. For example, you may see an hour rod, and that could be triggering your DIC. For example, you may see pancreatitis. That could cause DIC. Things like scorpion stings can cause DIC. Always isolate the trigger in questions related to DIC. All right, next topic is going to be the difference between heparin and warfarin. And in particular, I want to also go through the reversal agents for both of these. If I separate these out for you, heparin works by increasing the activity of antithrombin 3. If you have more antithrombin, you block thrombin. If you don't have thrombin, you don't have fibrin, i.e. you don't make a clot. And that's why heparin is a blood thinner. What's important for us to recognize is that there are different forms of heparin. For example, unfractionated heparin, in which you're going to be obviously following your PTT. Low molecular weight heparin, which is going to be more factor 10A specific in your clotting cascade. Low molecular weight heparin ends in parin, enoxaparin, dalteparin. You also have fondaparinux, which is a synthetic type heparin that is going to also be more 10A specific. For heparin, you're going to be using protamine for reversal. And the way that I like to think of it is heparin is starting with the H and H plus protamine. You can also use prothrombin complex precipitate, which essentially gives you back your clotting system. Warfarin, we all know, kind of inhibits your vitamin K dependent clotting factors. But why don't we just go into that in just a little bit more detail? It specifically inhibits vitamin K epoxide reductase. And when you have no epoxide reductase, you're unable to gamma carboxylate, i.e., you're unable to activate 2, 7, 9, 10, C, and S. And thus, you're going to have less active vitamin K dependent clotting factors, and your blood is going to be thin. So warfarin, what you're going to do is primarily follow the PT and INR, and you are going to be using fresh frozen plasma as your reversal agent, especially if the patient is acutely bleeding. You can also use prothrombin complex precipitate, but what's really important is FFP for active bleeding when you have warfarin overdose. And so remember, things like CYP inhibitors can cause you to have supratherapeutic warfarin levels. And if you start bleeding, you got to give that patient FFP acutely. And long-term, you're going to start waking up epoxide reductase by giving vitamin K. All right, this is the last portion of the webinar. We're going to be going through white blood cell disorders. And primarily, I'm just going to be going through multiple myeloma. This is the last portion of this lecture. So let's just stay focused. Take a deep breath with me. All right, let's go through it. Multiple myeloma. I want to let you know that multiple myeloma primarily presents as back pain in an elderly patient. When you're thinking about an elderly male who presents with back pain on your USMLE, and they, for example, have multifocal spine lesions, and then they have a high prostate-specific antigen, think about, oh man, do they have prostate cancer that metastasized to the spine? Or if they have, for example, back pain, hypercalcemia, and recurrent infections, think about multiple myeloma. Say that you have a female who has a history of back pain as well as a history of cancer. You want to be thinking of metastasis to the thoracic spine primarily. All right, very good. A 72-year-old male presents with recurrent bacterial pneumonias. He is noted to have an abnormal urine analysis, notable for nitrites, which kind of gives you the fact that he is also having UTIs. His childhood past medical history is normal. On physical exam, he endorses back pain. He is found to have an abnormal peripheral blood smear. Which of the following most likely is going to be seen? Hypocalcemia, low serum free light chain, qualitative immunoglobulin defect, or normal creatinine? What do you all think the answer is? So this patient likely has multiple myeloma. And in multiple myeloma, these patients get actual recurrent infections because of a qualitative immunoglobulin defect. When we're thinking about multiple myeloma, remember that the mechanism behind the hypercalcemia is the fact that patients with multiple myeloma are going to have increased osteoclastic activity that breaks down bone and releases calcium. What is the mechanism behind the recurrent infections? Well, remember that yes, you are making a lot of antibodies, but this is an abnormal proliferation of plasma cells and subsequent antibodies. So this monoclonal expansion of light chains are actually non-functional antibodies. And these non-functional antibodies contribute to a bad immune system, and thus you get recurrent infections. Very important for us to know. All right, ladies and gentlemen, that is the end of our session, but stay tuned. I want to give you the whole summary of what we just talked about. We first started with the complete blood cell count. We talked about disorders of hemoglobin, anemia, blood smear disorders, hemolysis. We talked about polycythemia, which affects your hematocrit as well as a little bit your hemoglobin. We talked about issues with primary and secondary hemostasis. And we talked about disorders of white blood cells. Specifically, we went into multiple myeloma, but in future sessions, I want to be going through leukemias as well. I just want to thank each and every one of you for your attention. And I really would just appreciate your support throughout these sessions and beyond. I'm really passionate about helping students prepare and integrate material for the USMLE. And I hope you got that passion through my webinar today. I do have some courses if you all are interested. One course goes through specific test taking strategies as well as a great rapid review. It gives you strategies on how to approach questions, how to manage your time in a question block. It kind of culminates all of my experience with private tutoring into one high yield course. It goes through everything from test taking strategies all the way to autonomic pharmacology and gross anatomy concepts. And if you want to also integrate a Notion study schedule and a set of lectures that helps you develop good discipline to study for the USMLE, feel free to check out my USMLE study schedule and productivity system class. Most importantly for you guys, I have free resources. My first aid outline, which integrates a lot of the biochemistry as well as the microbiology, and the Golden Style course, which has all of my old NBME lecture reviews. Most importantly, connect with me. I'm on Facebook, I'm on Instagram, I'm on Reddit. You can email me. And before each of you leave today, I want you guys to open in the chat box. Type in one thing that you learned. One key take-home fact that you can now integrate for yourself in your USMLE preparation. Go ahead and put that into the chat box before you leave. I know it's in this era of Zoom, it's like, oh, let me get off of the computer. Don't rush to answer the question. We talked about lead poisoning, HALT acronym. What are other things that you learned? A8, awesome. Excellent. Somebody learned about the beer mnemonic. All right, wonderful. Well, thank you guys so much. I'm going to stick around for questions, but otherwise, stay tuned to our next sessions. Thanks so much for joining in.